Everyone. We are on the session for surgery and comorbidities. I suspect you. I'm not Irfan Siddiq. I'm Rajat Verma. I'm a spine surgeon. I work in Manchester at the Children's Hospital in Manchester and in Salford. And I'm joined by Nick. The first paper will be after Nick has introduced himself.
Thanks very much. I'm Nick Hayden. I'm a consultant neurosurgeon in RNOH Stanmore, and I'm using a picture today, not just because my camera isn't working, but it allows me to hide my lockdown haircut. But without further ado, we'll move on to our first talk, which is Samuel Haynes from Taunton, discussing anticoagulant use in spinal injections. Is it necessary to discontinue preoperatively or not?
Hello, my name is Sam Haynes, and I am presenting to you today my project, Discontinuing Anticoagulants for Spinal Injections. Is it necessary? The background of this is that it's a review of a single spinal unit in Musgrave Park Hospital, Taunton, looking at all spinal injections undertaken in the time period 2014 to 19. I've done this as in Musgrave Park, no anticoagulation medication is stopped, reduced, or INRs measured prior to undergoing a spinal injection, which is, to my knowledge, different to any other department, certainly that I've worked in. Spinal injections are very common procedures, and the GIRFT's spinal report in 2017-18 recorded 211,000 spinal injections undertaken, which is about equivalent to the amount of hip and knee arthroplasties done in the same time period. I was unable to find UK guidelines regarding stopping anticoagulations prior to spinal injections, but these are guidelines from the American Society of Neuroradiology and European Society of Anesthesiology, and I've highlighted the anticoagulation guidelines for warfarin, which both advise INR falling to normal / below 1.4, antiplatelets should be off for 7 days, and DOACs should be stopped for 22 to 30 hours prior to the procedure. These are generally in keeping with the same expected perioperative guidelines for most elective procedures and can cause issues as miscommunication can lead to these instructions not being carried out. Why? Because of the theoretical risk of epidural hematoma seen here, which can be catastrophic in terms of long-term neurological function. As I previously mentioned, we've included all patients undergoing a spinal injection within the spinal department of Musgrave Park Hospital between 2014 and 19, which includes nerve root blocks, foraminal epidurals, caudal epidurals, facet joint injections, and SI joint injections. The results are fairly easy to dissect in that there were just over 3,000 injections performed in the time period, of which about 16% of patients, so 469 patients, were recorded as taking a blood thinning medication. This included warfarin, clopidogrel, aspirin, and DOACs with mixtures of all the above. As you can see, there were 0 recorded bleeding complications within our cohort of 3,016 injections. From our data, we can conclude that continuing anticoagulants in patients undergoing spinal injections is a safe practice and one that is still ongoing in our trust. This negates the needs for patients who can be elderly and have dossett boxes to undergo changes in their medication, which range from stopping the medication to having regular blood tests for INR checks prior to the intervention, which is invasive in itself. And of course, this leads to no patients being cancelled on the day of surgery due to high INR or forgetting to take their apixaban, which is otherwise an all too familiar scenario. No clotting events due to stopping these medications occurred as a result of our policy. Looking at the other evidence in this area, in an observational study which had 7,000 patients in total in the US, 4,700 patients didn't have their anticoagulant stopped without bleeding complications, and the other 2,300 patients did have their blood thinners stopped, of which there were 9 embolic events in the time off blood thinners, of which 2 were unfortunately fatal. Looking at potential shortfalls of this study, firstly, have I missed anything in the collecting of my data? I accept this is retrospective and recording of events isn't always perfect. However, I've also double-checked this with every consultant in the department who've confirmed that no bleeding complications have arisen, which have led to intervention. Lastly, Musgrave Spinal Unit covers a vast area in the southwest, and it may be possible that complications have arisen unbeknownst to the department. However, this would be unlikely for a couple of reasons. Firstly, due to the rapid onset formation of epidural hematomas, and lastly, that this is spinal unit for which these patients will have come to, and I'm sure that the consultants would have been notified of this if the patients had been discharged. So what next from here? Firstly, here in Taunton, the practice remains as such, owing to the lack of complications observed throughout the time where this policy has been the norm. Lastly, and most importantly, it's clear that more robust evidence is needed, as all there is in the literature is observational studies such as this and the aforementioned US study. And we would advocate a more robust evidence strategy such as a randomized controls trial to establish an evidence base and move forward. Lastly, these are my references, and thank you very much for listening.
Thank you very much for that.
Hello, my name is Sam Haynes, and I am presenting to you today.
Okay. Thank you very much for that. We'll have all the questions at the end. So the next talk is going to be a comparison of clinical outcomes and complications after minimally invasive extreme XLIF based on body mass index by Carlos de la Torre.
Good afternoon, and thanks for the invitation to this virtual meeting. I'm Carlos de la Torre, and I'm a spinal research associate at London Bridge Hospital. Today we'll be looking at whether or not body mass index has an impact on clinical outcomes after performing extreme lateral interbody fusion.
The minimally invasive extreme lateral interbody fusion has increasingly been used in the treatment of lumbar pathology, and the perceived benefits of this technique suggest it will continue to play an important role in the treatment of these disorders in the long term. Now, it's been proposed that the patient's baseline anthropomorphic characteristics may influence the clinical outcomes following ELIF. So the purpose of this study was to determine the effect of BMI on the clinical outcomes in patients treated with ELIF. For this study, we identified 104 consecutive patients undergoing ELIF for lumbar pathology between January 2013 and January 2020. Patient-related outcome measures were collected preoperatively and up to 12 months postoperatively. The prompts included were the Oswald Disability Index, the Visual Analog Scale for both back and leg pain, the Physical Competence Score and Mental Competence Score of the SF-36. Now, this is the WHO nutritional status classification. Based on this classification, and for the purpose of this study, we classify patients as normal if the BMI was between 18.5 to 24.9 kilograms per square meter, overweight or pre-obese if the BMI was between 25 to 29.9 kilograms per square meter, and obese if the BMI was equal or above 30 kilograms per square meter. 56% of the patients were female and 44% were male, with a mean age of 56 years. There were more patients classified as overweight, with 40 individuals, followed by normal weight with a number of 37 patients and obese with 27 patients. Now, for the ODI results, we can see on the left the preoperative baseline score for each BMI classification. And the image on the right shows a mean improvement in points from baseline to last follow-up. As we can see, normal weight patients had a mean improvement at 23.9 points, pre-obese patients improved 17.8 points, and obese patients improved 16.2 points. So there wasn't a big difference between three classifications regarding ODI. For the BAS back pain score, the mean improvements were 3.4 points for normal weight, 3.7 points for pre-obese patients, and 3.6 points for obese patients. Again, not a huge difference between the three categories. For the BAS leg pain score, the mean improvements were 3.4 points for normal weight patients, 3.7 points for overweight patients, and 3.5 points for obese patients. Not a big difference again. For the BCS score of the SF36, the reported mean improvements were 10.7 points for normal weight patients, 6.1 points for pre-obese patients, and 7.2 points for obese patients. For the MCS score of the SF36, normal weight patients had a mean improvement of 7.7 points, pre-obese patients improved 4.5 points, and obese patients improved 5.7 points. So, in conclusion, our analysis revealed that BMI did not affect the mean outcome scores in patients who underwent surgery of the lumbar spine using the ELIF approach. The comparison between baseline and last follow-up results demonstrated a similar improvement in all BMI groups and showed statistically significant improvements in all aspects of patient-related outcome measures. These results corroborate that the ELIF approach is an effective and safe treatment for lumbar pathology regardless of the BMI. Further follow-up at 1 and 2 years will continue to confirm the efficacy and durability of the technique. Thank you very much for your attention.
Thanks very much. And just for everyone, for clarity, we'll be taking all the questions at the end. So we're moderating them and going through and popping them into the chat so that we can go through those with the speakers right at the end. The next presentation is from Birmingham, from Awais Habibullah, whether or not they've found a solution to getting us all to use the BSR.
Hi there. My name is Awais Habibullah, and I'm one of the orthopedic ST6 registrars in the Birmingham rotation. And today I'm going to be talking to you about how the best practice tariff can help improve data entry in the British Spine Registry. So a bit of background, the British Spine Registry was introduced back in 2012, and at that time data input wasn't compulsory, which led to a variable level of engagement nationally, and there was poor compliance over the years. In 2019, however, NHS England and NHS Improvement introduced a best practice tariff to help encourage the input of this spinal surgical data into the BSR. Our main aim was to see how the introduction of the best practice tariff affected the compliance with the BSR. And we also looked at whether having a dedicated task force was actually of benefit to help reach the targets. And this was in the way of administrative support staff. So how does it work? Hospitals get paid by results, and nationally there are predetermined units of healthcare, and these are known as healthcare resource group. This basically incorporates specific diagnoses and procedures, and the cost of that care given is then reimbursed to the hospital. Since 2019, the base price of each spinal healthcare resource group dropped down to 90%, which meant you could only get 90% reimbursed for the costs. The only way to get the other extra 10% now would be via the best practice tariff. And the way to qualify for it is to ensure that at least 50% of operative procedures are recorded into the BSI in each trust. So we collected our data retrospectively from April 2018 to April 2020, and this is before and after the implementation of the best practice tariff. We collected the data using electronic patient records, theatre operating lists, and trust-specific BSR data. And we looked at the BSR as well and checked whether patient demographics, consent, email addresses, and most importantly, procedure notes were completed, because the procedure notes was the mandatory part to qualify for that best practice tariff. We also looked at HRGs and to which the best practice tariff would be applicable to. So 3,587 patients were included in our study, and 1,684 of these were HRGs and therefore eligible for a best practice tariff, 974 before BPT started, and 710 after. And that's a split of 1684. Now, as you can see, following the introduction of the best practice tariff, the procedural data completed improved significantly to 95%, and that was from 28% in 2018 to 19. When we look at also spinal surgical data, irrespective of whether it was HRG or whether they were eligible for the best practice tariff, we can see there's a statistically significant improvement here as well. And this just shows that there was better engagement with the BSR following the introduction of this best practice tariff. So our study shows that the best practice tariff has helped improve compliance with the BSR. We also found that the addition of the spinal outcomes coordinator that was hired at our trust helped support clinical staff with data entry. Only procedural notes were required to be filled in by the clinicians, and everything else was handled by the clerical staff or the coordinator himself. They would chase up what's missing and ensure that they tried to keep the BSI as up to date as possible. Now, one of the things we couldn't conclude was whether it was a financial incentive that helped improve our compliance, or was it actually having the administrative support staff. We feel it's a bit of both. We feel we may have been able to reach the targets without the support staff, but not to the point that we have been right now. What would be interesting to see would be to compare between institutions that have employed a new administrative support or coordinators to help with the BSI and those that haven't, to see if there is a big difference or not. One of the other points to note is that patient contact details were still only 67%, which then meant there was a low patient response to the patient-reported outcome measures, which then essentially can end up limiting the impact upon the clinical decision-making. So in conclusion, we can see that the best practice tariff does help improve BSR compliance and provides that financial incentive. And in the future, we can hopefully use the BSR data to aid with spinal surgery research. Thank you, and I'll take any questions you have now.
Thank you very much. I would like to invite, talk for the next speaker, which is impact of Parkinsonism in spinal surgery. The presenter is Davor Dasic.
Ladies and gentlemen, my name is Davor Dasic, and thank you very much for giving me an opportunity to present the impact of Parkinsonism in spinal surgery done at the Walton Centre in Liverpool. As we do know, Parkinson's disease is a progressive neurological disorder associated with rigidity, tremor, bradykinesia, instability, poor posture, and difficulty walking. Overall, some surgeons are reluctant to operate on this group of patients, particularly if this requires instrumentation. So overall, it's a controversial topic to some extent. As some of the previous studies have reported a higher complication rate for spinal surgery in patients with Parkinson's disease. Overall, there is a paucity of relevant studies. However, there are some, and I'll skip through those. Our study had a purpose of investigating postoperative outcomes, morbidity and mortality associated with lumbar spinal surgery for degenerative disorders and deformities in patients with Parkinson's disease. It was a retrospective database analysis and matched pair cohort analysis in a ratio of 1 Parkinson's disease patient to 3 non-Parkinson's disease patients. Groups were age and sex matched. We covered period 2012 to 2019 and compared 29 Parkinson's disease patients with 87 non-Parkinson's disease patients. As outcome measures, we used in-hospital mortality, morbidity, occurrence of any postoperative complications, but also compared BMI and ASA grades, and certainly recorded and compared the preoperative and postoperative COMI scores. There was no difference in BMI and ASA distribution between these two groups. However, patients with Parkinson's disease are more likely to have spondylolisthesis on presentation. This did not actually result in more frequent fusions in this group of patients. Perhaps there was some reluctance to perform fixations in patients with Parkinson's disease, and surgeons may wanted to keep the intervention to an absolute minimum. Regarding length of stay, patients with history of Parkinson's disease have significantly longer hospital stay and require longer rehabilitation period. There was no statistical difference in number of or complexity of postoperative complications between these two groups. Regarding postoperative outcome analysis at 3 months follow-up, patients with Parkinson's disease did worse only on 2 COMI outcome measures regarding their functionality. On the question, during the past week, how much did your back problem interfere with your normal work? And on the question, during the past 4 weeks, how many days did you cut down on things you usually do, like housework or recreational activities? Because of your back problem, patients with Parkinson's disease did worse than the control group. However, at the same period, 3 months follow-up, they did exactly the same on other questions in comparison to non-Parkinson's disease group. This difference at 1 year follow-up was annulled. There was no statistical significant difference between patients who have history of Parkinson's disease and those who do not. In conclusion, Parkinson's disease, according to our study and the literature review, is associated with increased frequency of spondylolisthesis and other deformities. Equally, it appears that degenerative changes affecting spinal column tend to be more frequent or perhaps even accelerate in patients with Parkinson's disease. Increased prevalence of spondylolisthesis among patients with Parkinson's disease did not result in increase of spinal instrumentation, at least not in our study. This finding may reflect, as I said earlier, a reluctance of a surgeon to perform spinal instrumentation in cases associated with Parkinson's disease. Thus, longer follow-up study and bigger cohort would be necessary. Our study showed only a short-lasting advantage in the functional outcome for patients without Parkinson's disease, but at 1 year follow-up, this advantage of non-Parkinson's disease patients was annulled, and there was no statistical significant difference between these two groups. Overall, Parkinson's disease patients experience clinical and functional improvement following the lumbar surgery just as well as non-Parkinson's disease patients. Parkinson's disease patients, however, require longer hospitalization, more physiotherapy, and have longer rehabilitation period. Thank you very, very much.
Thank you very much. Thank you very much for the talks. Laura, can we have all the presenters made, all the presenters made live so they can answer the questions live? Nick, for the first talk, any questions coming up?
Yeah, quite a few. So we've got a combination of comments and question that I brought into the moderated session. Neil Orpin's actually asked a very good question regarding whether cervical nerve root blocks or injections were included in this, but I think Ashok's actually responded and said that they weren't because they were done under CT guidance by the radiologist. So just in case anybody else was wondering that, cervical were not included. Dimitri Van Popters posed the question, are all your injections followed up, and would you be able to identify if they'd had bleeding complications or not? Samuel there?
Sam is not actually in the session at all, from what I can see.
I think it's been answered as well, lower down by Ashok, that all the injections are followed up in the ESP-led clinics. I guess Ashok has answered that.
Okay, so we don't actually know whether, you can comment on the bleeding. Yeah. Okay. So Mike Gravitz asked, again, I don't know whether they're going to have an answer to this if Samuel isn't here, but apart from bleeding, was there any exacerbation of radiculopathy secondary to perineural bleeding? By which I presume you mean rather than massive hemorrhage or concern, was there any minor problems with exacerbation of symptoms that could have been due to that? But again, I guess the answer is going to be the same, given these are followed up in an ESP clinic. Shall we move on to the next one? Because we've not got direct answers, and most of those have probably been answered online. That might be a worthwhile thing to do.
I mean, I can't see any questions directly related on the chat function, but I've got a question for Mr. Carlos de la Torre. In your cohort of patients with high BMI, do you think there is a learning curve of dealing with patients with a higher BMI?
Hi, can you hear me? Yeah. Hello?
Yes, we can hear you.
Hello?
Yes, we can hear you.
Sorry, you're getting cut off. Well, obviously, being an expert on the approach is important. And well, we've also found out that in high BMI patients, it takes a little bit longer to reach the lumbar spine. But in essence, the approach lets you basically approach it in an easy way, just as with any other BMI patient, regardless of the classification. It just takes a little bit longer because of the length that it takes to get to reach it, but it's not more difficult in essence.
Thank you. Nick?
Okay, so we're going to go on to the third presentation by Mr. Habib Abullah. There's two comments to start with, which I think are people's attention. Ashley Cole with typical political accuracy has pointed out that the BBT actually reduced the tariff to 91%, followed by an extra 10%, which means payment is 101% if that tariff is satisfied. David Bell, with all his incredibly hard work on the BSR, has offered his support to this work and this paper. And Mike Grevitz asked a question I also was going to ask, which is, do you have any estimate of the financial gain from the 10% BPT versus the amount of staff costs spent in achieving the target? Is Mr. Habibullah here? Is he muted?
He seems to have frozen, Laura. Is he frozen? Awais, can you hear us?
Him.
Yeah, just trying to unmute myself. Can you hear me?
Yeah, I can. Yeah, that's good. That's good. Go for it.
Yeah, good question. Fortunately, we haven't got the actual financial outcome in terms of what the profits made were, despite taking out the coordinator costs itself. But it's something we've been trying to chase up, so we're going to try hopefully have an answer for that soon.
Thank you. Neil Orpins posed a question regarding whether you think the changes that you presented, which were fairly significant, are just down to the BPT, or whether there were other measures that were also introduced in your cohort or in the time covered, which have improved engagement, given I think we've all probably got some experience of in our local trusts, other forms of engagement and campaigning have led to an improvement.
Yeah, I think gradually, if we did look at a very short amount of data looking at 2017-18, and there was a very mild improvement to 2018 prior to the best practice tariff. However, I think it was the best practice tariff that really sort of pushed to get this improvement seen, and which was the coordinator and the clinical team's engagement was the most important. It just sort of, I think they sort of bounced off each other and helped it. The coordinator that we had was probably our biggest asset. They were very, very engaged. They were present in MDTs. They would ensure every single patient was potentially contactable, and they would chase everything up. So I think the coordinator and the clinical team were probably one of the most important factors to gain this improvement.
Thanks. I know we're running over a little bit by its lunch, but I think the last Parkinsonism paper probably is generating a bit of interest. And Laura, are we okay to just carry on for a couple of minutes?
You've got 2 minutes.
Yeah. So question from Dimitri. Did you look at whether Parkinson's disease gets any worse, even transiently, I guess in the immediate post-operative period?
Yes, absolutely. No, interestingly, no. Immediately post-operative period was not statistically different from the patients who are not Parkinson's disease patients. However, and I have to stress this, their hospital stay was significantly longer, and they required much more rehabilitation input and much more physiotherapy prior to discharge. What we found out at the 3 months follow-up, they did slightly worse on those two functionality questions in comparison to non-Parkinson's disease group. And this indeed could be related that they actually need much longer period of rehabilitation and physiotherapy, even after the discharge, before they can pick up and reach the stage where they're pretty much equivalent with non-Parkinson's disease patient group. So literature is controversial on this. There are studies that reported higher incidence of complications. There are studies that reported that that's not the case. We didn't find it. So
there is another question from Abhijit Ghoshal about, do you take any special precautions or surgical technique changes when you're operating on patients with PD?
No. All of them were actually lumbar thoracic surgery group. We didn't do anything different apart from the general, I suppose, approach related to the comorbidities, anesthesia time, and managing with the Parkinson's disease as such from the general medical point of view. But technically, we didn't do anything different.
Thank you. Laura, are we out of time?
I'm afraid we are out of time now.
Okay, apologies. I'm sure you can catch up in the network lounge. Thank you, Nick, and thank you everyone for attending the session.
Thank you.